session on the cruise. I'm fortunate to have Dr. Darak, who's going to chair this session. Dr. Moita, ma'am, will be the vice chair. And we have a good amount of experienced panelists here. Dr. Manisha Agarwal is here. Yes, sorry. And Satyaprakash, Dr. Satyaprakash is not coming. Dr. Siddiqui, oh, yes, he's here. Um, Dr. Ashima is here. Dr. Bandari is here. Dr. Edwin, here. We have a responsibility to bring back this cruise by 5:30 because there is a function from the AIOS, so we have to finish. So let's stick to time. We have a 6 minutes talk and 2 minutes or 3 minutes of discussion. Dr. Aarti also will join us as the one of the panelists. So it's my great pleasure to introduce Dr. Madhu is here. An amazing work, and we have seen his work being presented in different forums across the world. Always nice and proud to see him presenting. One thing, I was just a judge at the apple tree. One of the major mistakes we do is a lot of people say that we have applied for patent. The question is, many things in AIOS is recorded. And if you go to the patent office, the first question is that do you have it being recorded or in the public domain? And if you say yes, even if it's a path-breaking Nobel Prize winning thing, your patent does not hold good. So even here, if you have anything which you feel is to be paid, you're planning to patent or applied for something, your patent office will, and first thing the lawyer has to tell you is to look, don't present anywhere where that is going to be recorded. And we have no control on what is going to be recorded or what is not going to be recorded. So please be careful about it. We had two similar instances at the apple tree, and both of them said that they've applied for patent, but this is, you can't just take out one thing out and because it becomes public domain. So please be careful about this, Dr. And try to keep it as closely, tight as possible. We can spend more time discussing this.
Yes,
Okay,
yes.
Dr. Madhu.
Thank you, sir. Thank you for the wonderful opportunity. So in the next few minutes, I'll try to share our journey of using a smartphone-based specular image as a slit lamp attachment. So why there is a need for this innovation? You see that we have specular microscopes that are costing around 10 to 15 lakhs, and they're not used in all the offices regularly. So we thought the existing equipment was expensive, not portable, and the software is also quite aged. Whatever we are using is from the past 5-6 years and changed much. So the idea was, now we are having these cell phones with very good cameras. So why not use these cameras to the imaging part and also take use of the AI analysis using an app. So the purpose was to develop and validate a low-cost, fully automated method of quantitatively evaluating the endothelium. So here, as I told you before, this is the camera that we are using. OnePlus camera for a OnePlus cell phone we have used, and we have developed an app, and we have attached it to the slit lamp. So the hardware is you need a slit lamp that has a high magnification, and smartphone should have, previously when we were using, we only had 2x optical zoom. Now the cameras come with 3x and 4x also, so you can also use this in regular slit lamps now. And a smartphone adapter that can be easily 3D printed or available in Amazon for 250-300 rupees. The most important part in this development was the software, which is AI enabled, where you can get the cell count, hexagonality, and CV like a regular specular microscopy. And you need an internet connectivity for this algorithm to work. So I'll not stress upon this technique because most of you know how you do a specular reflection. So when you do a specular reflection, this is how you see the, okay. So you see that second Purkinje image where you see that beautiful honeycomb. And when you go to the camera settings, we would prefer to have the ISO at 800 and shutter speed at 1/125. So that is the ideal for capturing the specular image. So now once that image is captured, automatically then we magnify that image, and this is the whole process in which it goes. It's called as the Krillhead algorithm, where it does a triple point analysis. So almost within 5 seconds, you get the results. So we compared the results of our mobile-based specular with the regular specular microscope clinically that we were using, and you can see that all the results are quite comparable. So in conclusion, I think smartphone-based imaging and automated analysis is going to be the future, where you want to have a good screening of the corneal endothelium. So the relevance and way forward, if we are able to get it into the market, I think it will be a very cost-effective tool. And this accessibility will make us to diagnose endothelial disease more accurately and improve patient outcomes. The thing that we are not yet coming out is the most difficult part is the capturing the specular image, because it requires a lot of time if you are not an experienced person. So now we are trying to automate that image capture also. The second Purkinje image, if we can automatically capture it, then it becomes even more user friendly. So that is the reason we are working on it. And I sincerely acknowledge my partners from Harvard GAMI. These young engineers from the Paulson School of Applied Science are helping me in this project. Thank you so much for your kind attention.
Thank you. And Chairman, Vice Chairman, the panelists, any questions you'd like to ask him?
I think you've already published this
In
article
a
in
TV,
National Institute of Health. Does it affect?
TVST, sir,
Yeah,
in TV.
I also saw it in National Health.
Okay, sir. Yes.
Does it not affect your patency?
Actually, patency, the US team is taking care. I'm not interested.
Anybody else?
Dr. Begin we were not able to capture the images on a specular microscopy because of the haze and early
Yes.
edema.
Yes.
Do you think it'll be more effective in capturing images which are already not being captured on specular microscopy?
Exactly. That's a very valid point, because here you can capture the image in the area of interest. Whereas in a clinical specular microscope, they have a preset 6 areas where only it captures. That too, it will be off the pupillary axis. But here, if you are able to do the specular imaging in the area of interest, it will precisely capture that area.
Yeah, that'll be very helpful. I think that'll make a difference.
Yes.
Anybody has questions?
And what about the hexagonality percentage and CV
Yes, sir.
percentage?
Hexagonality, CV, and CD. All the three we get.
It's a different software?
No, sir. The same. It's an application, sir. Actually, it's an app in the store, which yet to be commercialized, but it's an app that comes, and it will, after you capture the image, within 5 seconds, it will give you the report.
Did you compare this with the gold standards?
Yes, sir. We compared it with both NIDAC.
What's your standard deviation of count versus?
Yes. Can I go back?
You can just tell me.
Very comparable, sir. Not much of difference. In CV, some areas we had a difference, but we thought that was because of the areas in which we were capturing. There are two different areas that we are.
From a user point of view, who already have a now most of commercials are not that very costly.
Yes.
So where do you pitch your product in, for when if you are to sell it?
I think every if given a choice, I would like to do a specular for all my cataract patients. I think that is where this would fit in for all the comprehensive ophthalmology.
So what would be your range of, what would be the cost?
Costs are actually, GAMI is a thing that is specifically designed for developing countries. So we want to keep the cost very accessible. And we don't want to have it a subscription model, but like a one-time buy, and it automatically gets upgraded.
Thanks, Madhu.
Thank you.
Keep innovating.
Thank you.
Did you win this year also in ASCRS?
Yes.
Yeah. What did you win on? Same. Good. He's a constant feature in ASCRS in a winning list. Like to invite one more brilliant innovator, Dr. Ashish Sharma. And I got to know about the product, what he's going to show, when he had come in to Bangalore to give a talk. And I mean, he was smart because he gave the whole talk without showing a single image of this camera. And we had me and Dr. T.K. Ramesh, very renowned old teacher, both of us were sitting. And we said, how can we give him marks when he has not showed a single? Then we asked him. Then he said, I applied for patent, so I can only tell you what is not in the patent, right? And then we realize how important it is. So before you go into this, there are so many young people here. In fact, none of them in that apple tree knew about this thing. So you have applied, done, got a lot of patents. So you just give a few minutes about this and then you move to your talk, please, if you could. Because I remember the story very well. 2015?
Yeah, 15, yes.
Yes.
So patent means, patent-wise, there are two ways to go for the patent. One is you can file an Indian patent. The prior means prior conditions are, as Rohit very well highlighted. You should not be in the public domain at all before you pitch your idea and you have idea that this could be patented. And there are two ways to patent it. Either you file an Indian patent, and there is another patent called PCT. PCT application you can file. What PCT gives you is, PCT gives you a exclusivity, and it allows you that you are the first innovator, and it allows you time for 36 months. PCT report comes to you, and if you see that PCT report is very positive, and those 36 months are the ones when you will come to know that where I am standing and what could be the value of this patent, then based on that, you take a decision that whether you want to go for a national phase or not. Always remember, there is nothing called global patent. Patents are territorial. So after PCT gives you 36 months, then you have to choose the country. So, but that costs a lot. So we got great reviews on PCT, but I did not have enough sufficient fund, and I knew that means my cost effectiveness would be really on a different scale if I go for a US patent or something. So we applied Indian patent. Last week we got it. It takes a really long time. So last week got it. That's how the short patent journey is. Always one more point I would say, never file a patent on your own. Very important lesson, which I burned my fingers with one patent which I'd applied as a prior patent with USPTO, which cost $100 yet. But do not apply, because you are not inclined, you are not trained in the way that you can write a patent. Always use an attorney. Simplest example of my attorney, what he gave, he said, Ashish, if I am designing a chair, if you are an innovator of a chair, how do you write? You will write that I am making a platform where somebody would sit at 2-inch or 3-inch or maybe certain amount of height, and there are 4 legs on this platform sit, and there is a rest for your back. That's how you would write. But how I would write, I am designing a platform where a human body can be seated, elevated above the floor, either with the help of one leg or more than one leg. You got the point? If I have written it like 4 legs, if somebody removes and make a chair with 3 legs, my patent is infringe it with few more modifications. But when I put in a different language, so always use an attorney, means that's the bottom line. So means it's a very short journey, means because we are busy in our clinical practice, so but research is our fun, because I was trained in US, so that's where we got this bug. So I'll run through these slides quickly. So now we have proprietary rights, means these are my financial disclosures. So as of now, we have 2 commercialized imaging devices and 1 web portal, which is being used as a kind of a local testing. But 2 commercial devices as of now. MI-RedCam is present in 58 countries, thanks to the people and means who have encouraged us, like Rohit in the beginning. So now we have around 58 publications, and to our surprise, even today, yesterday, there was a publication in JAMA, which was a combined effort of SNEC with US and Arvind collaborators, and it has showed that MI-RedCam has the sensitivity and specificity for all the ROP referral cases, and that could be the global tool for care in ROP. And Dix Pro means I am very proud on my student who came with me as a DNB student, so credit goes to him. He came with an idea, and he have won all the awards. Even today he came, he said, sir, we won free paper awards as well. So because of my experience when he was there, in 2 years we could bring the device from bench to bedside. It's commercialized. Because of the COVID, it could not reach much, but still means it has got a lot of accolades. My dream innovation is rigs. I'll just tell you in brief that what the world could be with rigs. As of now, you must have seen your parents going for a blood pressure checkup, blood sugar checkup in clinics, grandparents or parents. What happens now? You check their blood pressures and you check their sugars at home with the help of these monitoring. So our vision is that you have a glass which can be prescribed by a diabetologist, and as soon as he's diagnosed as a diabetic, he can wear it with instructions that you use it every 6 months, and then it is connected with the AI. And after it is connected with the AI, it gives you an answer. You need a check. You do not need a check. Then your entire workforce, which we are still not able to find out the answers of DR screening, would solve. So that's our dream device. We are working on wide field imaging device because they are very costly. We could reach on our prototype up to the imaging where we can image retina, which is very close to the pupil as well. Rohit, I have already spent, I think, 4 or 5 minutes. I'll finish in 2 minutes, right? So these are all our publications based on our innovations. So few lessons I would share that what I learned in this 8-year journey. Whenever you have a concept, we all come with some kind of concept, but always establish that whether the need exists for it or not. Because otherwise our energy direction would be quite different, because you would work something which might not materialize. So always see whether, and as a solo innovator, social media is a big plus. That's what we did in 2015. Rohit remembers, we were uploading those photographs, and within 1 or 2 weeks, we got response from 26 countries because we were showing them images of pars plana and ora serrata, which people have never seen. So that's how we identified it is needed. Let's go ahead further. And as Rohit said, never, never, ever go into the public domain. So we filed our patent 2015. Our first paper came in 2016. That's where we showed that this is the prototype. So this is the patent that we got recently last week. This I already explained to you. Never stop a proto. Innovators, a brief advice. That's what the major mistake all the innovators, majority of them, they do. They are happy after proto, getting it published in a journal. But if you do not cross that road, you are part of a book. You are part of a chapter of a publication of a book. This is it takes slight effort to commercialize it, but then it has a value to make change at ground to many lives for you as well. So sometimes, I came from the United States after 3 years of fellowship. I didn't have money. I was struggling for even putting 7 legs, which was quoted by the person, who was about to make our device. But do not stop that. Means we had good friends. He said, okay, but you have shown the results. Go for crowdfunding. We started pre-launch, the way Apple does. We got funding, 150 bookings done within a week or couple of weeks. We got funding for our hardware. Then we needed money for software. So we again did a launch with little more price, saying, after 6 months, I'll give you this result. But you should be confident that, this can be done. People came forward, 50 devices sold, again, software came in. Again, remember, never give a half-hearted solution. We saw after us, a lot of people tried to copy, but they could not bring software. That's where the problem was. So bring complete solution, never half-hearted solution. Then international presence. Rohit knows it very, very well, the importance of international presence, because that's where you lead. That's where you defeat anybody who's copying. And being an innovator and into ophthalmology is a big plus. Because you are day-to-day finding difficulties, and you can present papers. So we were everywhere that time. If you really look at, we were an academy, we were published in academy, we were part of instruction course, we were on cover page. So that's how we take a lead. Take user feedback and solutions. We had initially only handheld device. People thought, it's shaking. So we brought the slit lamp mount. So now even a technician can do it. Then started ROP users. They came up with, they wanted 40D and 28D to use for more field, better field. So we brought that also. So that increased your revenue as well. And whenever any platform you have, market it. I'm marketing right now. You buy my device in next 3 days, I will give you 20% discount. So never lose an opportunity. And I would sincerely like to thank all wonderful people across the globe, especially Peter Campbell from US, Oregon, and Paraksha. The paper just came out in JAMA yesterday. Thank you so much, and thank you, Rohit, for providing me the excellent opportunity.
Any questions for Ashish? One of the most powerful sign of an innovator is how silent you can be. And I think Dr. Bakul Kamar is a classic example. You should be here, sir. You are the greatest innovator we have. You hardly speak. So I think Pooja speaks for both of you, I think. So what do you think? I mean, you are a retina specialist, innovators, thinker.
So first, I'd like to clarify that if you have some good idea, file a provisional patent. Once you file a provisional patent, and whatever you include in the provisional patent is protected. So it's not that you have to have granted patent or you have to have a complete specification file. So that's the first part. PCT, if your idea is not to go outside India, don't file PCT because it also costs. So if you are going to restrict it to India, file patent directly in the Indian Patent Office. Subsequently, you get 12 months where you can file complete specification. And during that time frame, you decide whether you want to file PCT or not file PCT. So you can file PCT subsequently. Okay. And PCT, if you are going to go to one region or one nation, it's not a good idea to file PCT because it costs much more when you try to enter that region. So if your goal is global, then only file PCT, at least 2 regions. So that's what I would like to inform. Now, there's always a Herculean task and there's always a failure. So failure rates are always high, which innovators won't speak. Correct?
And
It took 8 years to get the patent.
Yeah.
and one very important thing about personally about the camera he's developed. I'm not into retina, so I don't use so much of retinal images. But I realized that the aesthetic value of what you create has to be more beautiful than what you have created.
Yeah.
And that's what Steve Jobs told us.
Yeah.
And that's what he does.
I'll tell you exactly, you got the point. I copied our packing from Steve Jobs.
Exactly. It's white. And when I saw it first, I don't know when you put it up, the first thing is it captured the way aesthetically it's designed. It looks like you're opening an iPhone. And the second is, to have creativity, you should have much more talent than ophthalmology. And he's a very good guitarist. And like Steve Jobs, when your brain thinks in a non-medical way, you actually create more beautiful things. And your design, the box, and all that is so aesthetically.
Now, it was white, you remember?
It was white.
Now iPhone comes in black. Now we have changed our packing to black.
I still like white.
Okay.
So please.
So the other part is that, like he said, go to the attorney. Now, when we do as a scientist or a clinician, we are very focused. So we go in a particular way where we like. When somebody else looks at it, he will look at it from a perspective of how broad that innovation can be protected. And the classic examples, I think everybody knows about Pintusio keratoprosthesis.
Yes.
So that gentleman, that ophthalmologist, he designed it, and this will help you. He designed a keratoprosthesis Pintusio, and he went to his patent attorney. And attorney drafted the claims in such a way, he thought, I'm not going to sell it, it is for my satisfaction. But after 3 or 4 years of granted patent, a team of defense ministry reached his house just to inquire, can we use this patent? So can you think Pintusio keratoprosthesis had an application in defense research, and he made, according to him, he made significantly more money and got back all the investment, not from Pintusio keratoprosthesis, but from that. He became really rich. Mm-hmm. So that's what the attorney does. They try to broad base and see where your claim fits into. Because if you try to make the claims too broad, then you are infringing somebody and you won't get a patent. If you try to make it too narrow, it becomes so narrow that it is not more interesting. And then anybody can copy it. Like he gave example, 3-leg chair and 4-leg chair. So thank you very much.
Thank you, Ashish. But we still believe that you should keep white. Yes, ma'am. Ashish, sir, you.
hearing about. So what is the basic difference between this and all others that are available?
So major difference is cost. And I'm not sure, which you are. So I'll tell you a few difference. For example, if you are not talking about the wild field cameras are the ones, which can capture, the entire from discs to the ora serrata, but they cost 80 lakhs or something. Okay.
Oh.
So you have to give me an example. Then that's the only way I can compare. Probably Remedio. You are talking about Remedio. Remedio. Yeah. So where Remedio fits in, for example, even if you meet, I'm not. They are very good colleagues. Anand Srinivasan, I review all his papers. He sends all these papers. So wonderful. Means he's doing wonderful on the AI part. For example, as of now, still we have not incorporated AI. The reason is the output from different phones comes different. So that's where we are a little inferior from Remedio, because our AI is in process, but because of the differential inputs, the answer what AI has to give to us is not giving correct, which means Remedio is doing much, much better than us. But where we take a lead is that Remedio can't capture periphery. Even all over, even you talk about Zeiss, you talk about Topcon, you talk about any table mount fundus camera, they can't go to the pars plana ora serrata, which we can go. Any patient, dynamic imaging, they can't do it. We can do it. Image quality wise, ROP, if you see ROP, it is a big hit across the globe. That's how entire world is using. So ROP, now it is established that this has the same picture quality compared to 80 lakhs RETCAM in terms of referable ROP, but it is inferior in peripheral lesion in ROP as well. Okay.
Thank you, Ashish. And he'll be here. And after we finish, if anybody wants to interact, you can interact with him. It's always pleasure to invite Dr. Mohita Sharma. I think one of the very, very big things a society of any society in this world has created is to create a registry of rare eye diseases, rare eye conditions, and many things on this. It's just not about having a registry of it. It's about a complete change in the mindset of how a society should work for. Of course, conducting meetings and other things we all do, but the society should work for bringing in people together to create an environment or ecosystem where they can work together to bring in more education into these diseases. And I don't want to introduce her. Everybody knows Dr. Mohita Sharma and her team. She would represent the Rare Eye Disease Registry in this innovation. I think this is one of the very good innovations which happened in the last 2 years.
Thank you so much, Dr. Rohit. I thought it was a little misfit, this topic in innovations, but you very beautifully put it together in the innovation session itself. And yes, this is something which since as it says, it's rare eye diseases, so it's rarely talked about. So I'll be happy to talk about it. And before I start talking about it, it's an idea which was generated by the ideas man, Dr. Rohit Chetty. And so all credits to him. And it was the support of CIPLA because of which we could take it forwards. So thank you so much to you all. This. So first of all, whenever we talk of rare eye diseases, everybody tends to think, why should we even bother about these rare eye diseases? Yes, it is important to bother about these rare eye diseases. Imagine a situation where any of your near or dear one had a rare eye diseases and there was no proper diagnosis. The doctor told you that there's no proper diagnosis. I'm not sure what disease it is. And the doctor also said that there was probably no treatment for it and he was not sure as to what to do about it. So imagine what you would feel. So it's the same thing that our patients also feel. And we all have come across patients where we made a diagnosis of rare eye disease, and then they kept following us year after year, asking us as to, the same question kept coming, and they kept asking us, is there any new treatment which has come for this? And every time we have no answer for that. All we do is that we give some psychological support, and we just tell them that some researches are going on, and probably in a year or two you would have some treatment, and they go back with some hope, and then they keep coming to us year after year. So probably by doing this, taking this initial step, we would have some answers for these patients. And of course, as in our country, we know that there are consanguineous marriages, so there is an importance of genetic analysis, genetic counseling, so that at least even if there is no treatment, they can plan their families, they can plan their career. So it's important to know about these diseases, and as well as to work more for finding some treatment for these diseases, though it's a slow process, but somewhere the step has to be taken, and that's the step that Women Ophthalmologists Society took, and that is what I'm representing here today. So salute to this lady, Irene Hustles-Momini, who is called the Ginny Gentic. She envisioned the fusion of ophthalmology with medical genetics and is a founder of Johns Hopkins Center for Hereditary Diseases. According to her, every rare eye disease is a piece of mysterious puzzle in ophthalmology, and she put the pieces together. And she's done a lot of work, and we need more and more people like her who do this kind of work. So for rare eye diseases, this is the stepwise approach which has been taken. Step 1 is the red diagnosis and knowledge of syndromes. Step 2 is genetic tests. Step 3 is creation of registries, which we are doing. Step 4 is genetic counseling, and step 5 is genetic and other treatment. So step 1 is red diagnosis. As you can see, though it is called rare eye diseases, there are many diseases you will see here which you do see in your clinics, and which you do come across, things like retinitis pigmentosa, Stargardt's, corneal dystrophies. This is something which we all are seeing. So knowing how to diagnose them, and especially correlating them with syndromes, is very, very important. Just giving an example, now this is a IGO red special issue which was published last year in July, where there is a lot of knowledge of these rare eye diseases and syndromes. And when we want to thank IGO and the whole red editorial team, many of the girls are sitting here who are responsible for making this happen. And this is first of its kind document all over the world which talks about rare eye diseases and gives a lot of information. Example being a simple thing like we saw, if somebody sees a case of hypertensive retinopathy in a young patient, and along with this corneal erosions, posterior lenticular retinopathy, we have to look beyond. Is it a syndrome? Now, if we have that knowledge where we look beyond and we look for chronic renal failure, sensory neural deafness, and other ocular signs connected to it, then only we would know it's a syndrome. It's an Alport syndrome. So only when we have a knowledge of this would we be able to diagnose diseases. Similarly, a patient with phacoemulsification with a IOL implantation, anterior vitrectomy under general anesthesia. Now, when we look beyond, we look for things like generalized ichthyosis, mental retardation, spastic paralysis, etc. We know it's a Sjogren-Larsen syndrome. So first and foremost step is knowledge of these, and otherwise these rare eye diseases get missed, and that is what is important. Similarly, retinitis pigmentosa, it is already known that there are so many known mutations, and when we know about these mutations, we will be able to diagnose that as to which particular syndrome it is with which the retinitis pigmentosa is associated. So it has to be a multidisciplinary approach involving the physician, pediatrician, geneticist, and a genetic counselor. Now, the step 2 in this in the stepwise approach is genetic testing, which should be an integral part of the diagnosis. Whenever such patients come to us, the diagnosis that I had shown, whether it's retinitis pigmentosa, corneal dystrophy, how many of us actually advise genetic testing? I feel none of us or very few of us would even think of getting a genetic testing done, because the big question is it actually useful? Why should we get this genetic testing done? Even if we get it done, what is the big use of, and how will this help the patient? So here I want to say that this step 2 has to be taken by all of us, and it is not difficult at all. And because if we take this step 2, one is when we know the known mutations. Since there are known mutations, we'll be able to make our diagnosis of syndromes better. Second is we will be able to predict whether such a risk is present in the first degree relatives or not. Thirdly, now gene therapies are coming. Now the first gene therapy for eye has been approved. I'll just show you in the subsequent slide. Now since this is approved and gene therapies are coming and clinical trials are going on, only when we make these diagnoses we will be able to identify which are those patients which need to be directed towards these clinical trials, and we would have a pool of our patients already ready when the gene therapy is there in our country. So this step becomes very, very important. As I said, so many known mutations are already there, and when they're already there, all we need is a little bit of knowledge and advising our patients those genetic testing, so that we are able to find out who those patients are who would actually benefit from these treatments, which are actually almost arriving. So step 3 is creation of registries, which is what the red group has done. And this is a rare eye disease group, which was created 2 years back by Women Ophthalmologists Society. And in this group, we found that there were certain registries which were already existing in some parts of the world, but there was no such registry in India. And even in the world, there were very few registries of rare eye diseases. So we thought we should create such registries, and these should be registries at the national level. And this is what the rare eye disease group has started. So the steps in this are going to be national registries in genetic testing, counseling, rehabilitation, support groups, and low vision aids. So this is the pilot project which was started where national registries are getting created. And in this phase 1 has already been done, where some diseases have been identified, leads have been identified, coordinators and investigators have been identified, and ethics clearance has been taken. The second phase, where templates have been designed for these diseases, and now the process of training is getting started for all the investigators. And as yet we are ready to enroll investigators, so anybody who's interested can become an investigator for these diseases, and they can apply and we can get back to you. And third phase is phase of data capture and audits, and then analysis of data. So a lot of the good thing is that a lot of people have shown interest in getting enrolled as investigators for rare eye diseases, which gives us a lot of hope, which we feel that this was a subject which is not being discussed, and since it's now being discussed, so many people are coming forwards to be a part of it. Step 4, as I said, is genetic counseling, very important for emotional and psychological support, for family and career planning, and for treatment and research options. Now here I just want to share, just as an example, this is the first gene therapy approved for eye diseases, and it is for a specific mutation of RP for Stargardt's disease. This is not available as yet in India, but it's an single intraretinal injection, which has shown good results in certain cases of retinitis pigmentosa. And so this is something which propels everybody into action, that there is gene therapy is now becoming is going to be the next thing which is going to be there for these rare eye diseases. Though these things, obviously it's because of after so much research it is expensive, but I'm sure the rates will come down. And these drugs are often called orphan drugs because nobody likes to work on them. These diseases are also orphan diseases, but that's what we all need to do. We need more work on these. So finding the unknown, this is my last slide, I think. Manpower required for discovering the world of genetics is sparse. We have an estimated 22,000 genes, and we know over 6,000 single gene disorders and complex diseases, but the causative mutations have been identified in fewer than 4,000 genes. So as you can see, a lot of work needs to be done on this. And that's what Red Group is trying to do, and that is what your support is needed for. We'll skip this if time is less.
Any questions for Dr. Moita? Wonderful work, and a big round of applause from all of us. First thing for the work, the second is for making society also believe in making a collective decision and creating an ecosystem for everybody to take it forward. Dr. Darak or anybody wants to ask anything? Want to say something?
Okay. So, by definition, orphan drug or a rare disease is not defined in India. In US and Europe, there's a specific prevalence and incidence of a disease where it qualifies for a rare disease. So, and for the rare disease treatment, there are special incentives by government of US and EU, which is not existing in India. That's why most of the innovation for rare diseases happens in that place. And the clinical trial requirement is minimal for a rare disease. So even if you have, so the last example which I know is a 25 patient single arm study and product was approved. Okay.
So you're right that in India, the as per the regulations are not favoring orphan drugs, and a lot of advocacy work needs to be done. And outside India, there's a lot of exemption on excises, taxes,
so
etc.
maybe 2-3 years down the line, we will have that
Yes.
policy.
Yes.
I think you should encourage the government. You're working with the government.
Yes.
And I think we'll have to also thank CIPLA and one of the first companies who agreed to fund something which they have no drug on. And none of these, they have directly or indirectly not associated anything. And I think we need pharma companies like yours to be more proactive into those orphaned areas of it and not always look only from the business point of view. I think this needs also a big thank you, and you people have to be a little more active. I think we have to, we have to things there. I think there are a lot of things which needs to be done. I think after AIOS, I think if you can work on it, it will be really helpful.
And the suggestion is, do you correlate phenotypic, genotypic in your program?
As of now, no. That will be a second step.
Okay.
Right now, we are just
Because
collecting the
funding
clinical
is a big
data.
challenge.
No, but see, whosoever enrolls, there will be phenotypic. He will have done it. He or she will have done it. Then genotypic, whosoever wants to do it can do it. But if you organize well, I can talk to GSBTM, Gujarat State Biotechnology Consortium. Probably they will do in a research mode, and for a particular disease where they get interested, they can
You
do
should
it free.
probably include him as one of your advisors.
As an advisor.
Because
and
his knowledge
take
is
his help.
phenomenal.
Yes. Thank you.
Thank you, Dr. Mohita. I would like to introduce Dr. Reshma Ranade, and she just finished her fellowship, but a very, very good clinician, scientist, and a fellow with us. This is a very important experiment which we need to discuss about, because recently we had the IOLs, which had everybody were talking about endotoxins, and one report came as negative, somebody else came as positive. There were multiple confusions about these endotoxins from an IOL. It's one of the most challenging thing is to study the endotoxins. Each person has a different way of looking at it. Most of the time, you are taking the fluid from the lens, or and then you test it out. Sometimes you get something, sometimes you don't get something. So during that time, the company did approach us and say that, we really want an answer for this, because we want to change a way of how the production is, whether the problem is with the lens or the fluid. So without actually creating a similar path of what is being done, just taking the fluid and testing, we created a new model of looking at endotoxins. It's just not for this IOL. Let's forget about the IOL. It's done and gone, done and dusted. Now we don't see those stars anymore. But this can be a fantastic model to study a lot of these factors on IOLs and other things. And this is a great model because, and this is again a completely new model. So she was there working during at that point of time, and I told her to just make a small presentation of how you can test endotoxins, because all of you as cataract surgeons should be aware of this. Because one day one company gives you a report, second day some other company gives you a report, and two are not going to match because the way they test is different. That's a background. Dr. Reshma.
Thank you, sir. So I'll just skip the introduction since sir has spoken about this. And so all of us know that TAS is one of the dreaded complications for an anterior segment surgeon, and there are multiple reports published in literature. So in the light of the current events, we were thinking if there is a way we could identify and isolate these compounds from the IOLs, which were causing this reaction. So we had a sample size of 12 IOLs, and if you see, they were grouped into implicated, non-implicated, and controls. So what we meant by this was that the implicated IOLs were taken from the same lot of the IOLs in which were implanted in some other patient who had developed a TAS reaction. So these were sterile IOLs which were taken from the same lot. When we mean the non-implicated, these were the IOLs which were taken from a different lot, and the patient did not develop a TAS reaction when a similar IOL was implanted from the same lot. And then we, of course, had the controls. Now, what we did with these, after sterile handling of the IOLs, the fluid along with the IOL was transferred into a 2 ml Eppendorf low binding tube. And this solution was then agitated along with the IOLs for 4 hours at 900 RPM. And then we isolated the solute by a process called as leaching. Now, what is leaching exactly? It's the process, by definition, it means the process of a solute becoming detached or extracted from its carrier substance by the way of a solvent. So when these IOLs along with the solution were agitated, whatever compounds were there within the IOL, they all came out into the solution, and that was what was analyzed. So we ran basically 2 tests for these. So this was the grouping of the IOL. So we had 3 controls, 4 implicated, 4 non-implicated, and a toric IOL, which we used to compare. So we ran basically a sterility test to find out if we could identify any organisms. These samples were aseptically inoculated into the brain heart infusion broth and then incubated for 37 degrees centigrade for 48 hours. And it did not show any growth after 48 hours of incubation, which meant that the samples were sterile. So we went ahead and we did an endotoxin assay test. So this is the reagent which is used, which is called the LAL, which is the Limulus amoebocyte lysate, which is also known as a bacterial endotoxin testing. And after it was incubated and this after the addition to the substrate solution, what did we find? So what we found was quite interesting, because if you see the non-implicated and the implicated group, both the group of test tubes show a pink shade, which means that the endotoxins were identified in both these IOLs. We were probably just lucky that the non-implicated samples were the patients who did not develop a reaction, while we did not find anything in the control group and the toric group as well as the blank group. So this was the first step to find out if we found an endotoxin, which was done by the colorimetric analysis. Now, what was important was to find out the concentration of this endotoxin. So the FDA regulation says that the level of endotoxin contamination, which is acceptable, should be 0.5 per ml. And now what we found was that the control group, the implicated one, and the water control samples had a concentration below 0.5, while the non-implicated ones and the implicated between 2 to 4, so 2, 3, and 4, had endotoxin levels beyond 0.5. Inferring a high, heavy load of the endotoxin concentration in the samples. We went one step ahead and did a soluble factor analysis in these samples. So whatever was the supernatant which was identified, we then did a flow cytometry analysis to find out if we could identify any markers in that. So we found a significant elevation of the interleukin-2 when we compared in the implicated group as compared to that in the controls and the non-implicated ones. So to summarize, we investigated the IOLs and the packaging solution, but what is important, as Sir said, was the process was very important, which was called as the leaching, because that was what identified the endotoxins. And we observed the presence of the endotoxin in the non-implicated as well as the implicated group, and the concentration was found to be more than 0.5 per ml.
If you can go back. This slide, no, this one. This slide is probably the most important slide for all of us, because minute we see a problem of TAS, we only look at the implicated group. And we think that the non-implicated group is healthy and we forget about it. The question is, it's not that it's completely healthy. The batch, every single batch will have a problem. Only thing that the concentration is not so high for it to cause a thing. So just not trying to just isolate only those batch numbers and take it. Because in this case, maybe the packaging, it was not a problem with the sterility. It was maybe problem with one of the fluids or whatever. And they changed and everything became normal. So it's very important that many times when you see a report, if you go back to the report, this is never done. Each IO trying to leach. Leaching is never done. What they do is take the fluid out, and in the fluid, most of the time, everything comes as normal. So leaching as a process is a very big innovation especially in TAS. We forget about all this as soon as the story dries off. But minute we get one more, and why it has. If we go back to the interleukins part is, the question is, in our own cases, we have used this unknowingly, we have used the same type of lenses, and the person did not react at all. There was no TAS in them. That's because the body's immune response is so strong, it dampens this completely. And why does it come to only certain set of individual? Is because his response in the body is not so strong to dampen it. So your individual response also has a huge role in this. So this is the take home point from this, and there are different ways of actually looking at measuring the toxicity of anything, whether it's IOL, tomorrow contact lenses or anything. Any question, Ashish?
Very closely follow these biosimilars.
Yeah.
So biosimilar example, I will tell you what happened if you remember, India is the first country. We are the, probably, we lead the world in biosimilar because was the first country when first biosimilar ranibizumab was launched in 2015. But I'm not sure how many are, here retina specialists, but you must be remembering around 2015-16, they had some inflammation with few batches. All right. Now, after that, there's no inflammation. We have now 2 more molecules, no inflammation. So the story goes behind that what happened in 2015, we were following this endotoxin limit, which was defined by ISO. And ISO limit was 0.5 EU per ml. But over the time, what happened, retina and anterior segment, they are kind of a different chamber and the endotoxin affects in a different way. FDA was not differentiating it. But in 2016, FDA realized that even if you tite it less than 0.5 EU, is still in retina, you might find some inflammation in some of the cases. So then there was another advisory from the FDA, it came into play, and now the tite limit is 0.3 EU per ml. So 0.3 EU per ml, since it has come, now there is no biosimilar which is causing any kind of inflammation. So even if you look at Lucentis, when the first trial in 2006 was, the inflammation rate was 0.17. So over that time, this FDA guidance and this improves. So it means endotoxin in this particular sense, I would say, even Rohit, if you can work with the industry, tell them, because now these Lupin and our Intas, they maintain endotoxin limit in these anti-VEGFs approximately 0.08, which is much, much tighter. So if they can put it much tighter limits, then, things would be in a great shape.
And you know what, more than one is the endotoxin level of your thing. If this person's, one of these molecules is already higher, even before you gave an injection, and you inject something which has an endotoxin, you will do a double whammy effect there. And
true, that's what brolucizumab is doing.
Absolutely. Thank you, Reshma, and wonderful. Anybody has questions for her? Thank you. Yeah, we have a question.
There is something like intraocular lens. They have this endotoxin level, but the same is for the medical devices also. So we have only one endotoxin level for the intraocular devices. But actually, the hydrophilic lenses, hydrophobic lenses, all they have a different properties, and that kind of EU has not been defined at anywhere. So this thing has to be taken care of.
Yeah, that's one of the reasons. What we did was we used hydrophilic We use the hydrophilics, no control of only hydrophilics, and the U content of hydrophobic. We use the so every lens had a different control. We never used one control for everybody. That's one of the reasons. Thank you. Yeah, Edwin.
Yes, it's mainly for the anaerobes and fastidious organisms. So you can get all the cultures. Yes.
Thank you. Something which this particular paper, what Dr. Sharon is going to discuss is what we need in our country is to have a healthy collaboration of the pharma with the clinicians or clinician scientists, because every time they bring in a drug, many times these drugs are launched without much of background, and everything is just given, most of the details are just given, which is copy paste from something which is published in some insignificant journals. So this new product which the CIPLA wanted, they wanted Sharon to work on this mucin and create an experiment of how this hyperosmolar stress would behave in this product. And this is something which she will discuss in this session.
Thank you, sir. Thank you for including me in this session. The talks till now have been brilliant. So very often what happens with all of us is that we are thrown, so many different drops, which we see every day, and it's very difficult to decide which would work for our patients, which are toxic, which are, how do you decide? By looking at physical chemicals, there are so many additives, so many different constituents, and sometimes it's very difficult for us to choose. So in our tear film, and I'm sure I don't need to highlight this, but along with, because the aqueous and lipids are something which are highlighted all the time, we only think of replenishing or taking those into consideration. But the mucin in our tear film is not only at the layer of the cornea along the microvilli, but there are also soluble mucins which help the tear film be more stable. And along with the lipids, they're an extremely important constituent. So some of the newer medications, the lubricants which are available to us are, those which help with the mucin stability, the mucin replenishment, and therefore, evaluating them would really help and help us guide our treatment. This was the paper we recently published in the dry eye special issue of the IJO. So the rationale of this study, as I was saying, is that we know that with dryness, there's a lot of inflammatory stress which comes up, which is triggered by the NF-kappa beta pathway. And irrespective of what kind of dry eye we have, over time, because of the inflammatory stress, there's a loss of the conjunctival goblet cells which get affected. This leads to altered dry eye, altered tear film stability and dry eye. Now, in an experiment, if we have to check it, then we need to have markers for which show us that there is a hyperosmotic stress, and NFAT5 is one of these markers. How do we induce this hyperosmolar stress in the experiment, in the lab, is by using sodium chloride, which is applied on the cells and the corneal tissues to try and stimulate this. Right? Now, usually when we're looking at various experiments, the most common experiments we do are on human corneal epithelial cells, cultured cells, and conjunctival epithelial corneal cells. But we do know that sometimes that may not be available to us, or it's not easy to culture. So here we took it a little different. We did what is called ex vivo. So we have in vivo, which is in the body, in vitro, which is lab in the Petri dish, and this is ex vivo, which is tissue which is taken from the human body and then grown and used for the experiment. So these are ex vivo corneoscleral rims. And the idea was that we try and find out how this combination, which is a very common combination you'd have heard, polyethylene glycol with propylene glycol, how it affects in the mucin secretion. So this was our purpose, to develop this model, the ex vivo model, by using the donor corneoscleral rims, and then test out this drop to see how it affects not only in reducing the hyperosmolar stress, but also its effect on the claimed mucin, which is there. So we took 8 corneoscleral rims, which are, once we've done the penetrating keratoplasty, these rims are left behind. So we use those rims. They were cut into equal sized pieces, transferred into a special medium, the DMEM medium, and incubated. And then using qPCR and ELISA, we used, incubated them and then used it to analyze the supernatant coming from that. We also match it, we use the conjunctival and corneal epithelial cells, but for this presentation, I'm just talking about the corneal scleral rim. Once we did that, we saw that surprisingly, in the human corneal epithelial cells, because we're looking at mucin expression, the human corneal epithelial cells actually had very low mucin expression, which is expected because they don't have goblet cells, so there's no mucin coming. The conjunctival epithelial cells also showed a fairly low mucin, but the rims showed much higher mucin. So obviously, it's a good platform for us to check what we are doing. We then applied the PEG-PG drops on those corneoscleral rim explants, which we have incubated, and monitored them with the NFAT, which is the hyperosmolar stress marker, and the MUC5 and MUC16, which are our markers for mucin production. Right. Now, I'm not shown all the results from the study, but the most important are these two graphs, these two sets of slides, which this one shows the effect of this drop on the hyperosmolar stress marker and the mucin. So in the first graph, if you just, I don't have a marker here, pointer. So if you see the first one, the NFAT, which is the hyperosmolar stress marker, you have the control, and with the hyperosmolar stress, this increases. With the 1% PEG drops, which is what is available to us, there's a significant reduction. Note that if we increase it too much, that's also not good, and that shows the toxicity which increased concentration of drops can do. But very interestingly, once we have the PEG drops and it shows the increased expression of the mucin markers, both the MUC5 and MUC16. So it implies that these drops do have an effect on reducing the hyperosmotic stress response. And it also, if you see this one, there's a rescue effect. So once there's an increase in the osmolarity, with these drops, we can try to maintain the level of osmolarity, if not reduce it. The second thing is also important, that we can rescue it from a process where it has increased and also help to maintain that mucin secretion and the hyperosmolar stress response. So collectively, we can show that medications which contain this, and this was, it's in the paper, so this is Flogel Ultra, but otherwise, generally, this is what this group of medications is expected to do, and we now know how it does it, because otherwise, we were just going by what is there in those papers.
So one of the biggest challenges we all face is companies come up and give a product with that 5-6 different combinations. Why this model is important is they say that, okay, Optiv does not have this, I will add this. Or somebody else doesn't have it, I will add it. So when it so happened that some medical affairs from Cipla had come and said, sir, you should write this product. We have added so many things. I said, this is not a cocktail which has so many things and it gives you that effect. See, you are picking up things which others don't have it. Then they asked the question, which I feel a lot of companies should ask, and all of you as clinicians should ask, have you really tested that whatever you put? I think this has polyethyl glycol and propylene glycol, sodium hyaluronate. So, and it has the HP-GOR. So it's a mix of, say, a Cysteine Ultra with refreshed tears and multiple things. Then they said, okay, can we conduct an experiment to do it? And there are good models. In the past, to create this experiment, we had to do it on a rabbit or one of those animals, use it, sacrifice it, and all that. Now we have fantastic models where you can do everything on a Petri dish. And you can create any model you want. You want to create a dry eye model, you want to create a keratoconic model. And all you need to do is from companies that put those drops and see. In that way, I think they passed the test that whatever the beautiful combination they've created. One is it creates mucin, and one other one it holds the lipids. That means it is one where you can use it both for evaporative and aqueous deficient dry eye. Because the challenge for us is sometimes you need something for aqueous, something for lipid, something which improves the lipid. So in that way, I think you have passed that test, and this is a published work what I'm speaking. But most important thing is that you also have to more other products, just don't mix things up, and it's not a culinary kitchen where you can mix and use. expect it to work. Thank you. Anything?
What is the role of that HP Gore in that? Means regarding the mucin secretion.
Anthony does
exactly.
here.
So how it will affect the mucin secretion or mucin expression in that way?
Dr. Anthony does is here. No, not here.
Polyethylene glycol and PG, both will take care of. Yeah. Because what I know is HP Gore is related to viscosity and binding agent. So you can increase the concentration to increase the viscosity.
So HP Gore is necessary if you are holding, if you are putting more products into it. If you're putting a sodium hyaluronate, your PEG, by itself they are extremely naughty ones. Like, you know, she showed one slide. If you put more of it, they start doing opposite of what they're supposed to do. But this holds them. It's like a policeman. It holds them in a nice ring so that they don't go out of it. But what happens is that companies should be always able to promote these kind of experiment, which will tell us whether it's worked or not. And it's my pleasure to introduce Dr. Pooja Kamar. She's going to speak on... Are you speaking? Yeah. Your name is... Okay, what are you speaking on? No. This must be old one. Just, yeah, I know. And she also happens to be his proud niece. And so she's speaking on genes. I think we had a beautiful talk by Dr. Mohita ma'am about the whole red eye diseases. And what is happening is we will show that the drug you showed, I think Dr. Purna Chandra is here, and he is working on retinal gene therapy. How much does that drug cost? It's the costliest drug in the world, if I remember, 8 crores? 6.4 crores. I believe they give you, every time you order, you give 2 injections. By mistake, if you drop it. So Pooja is trying to say how you can bring it and affordable to your registry you're doing. This is directly connected to it. The whole vision is that it should be so affordable, like what people can afford a simple surgery. Dr. Pooja.
Thank you, sir. And I would like to thank CIPLA for organizing this session, which is a little bit unique, and it gives us a lot of views also outside. So Mohita ma'am has already made my job simple in saying that, yes, you do need gene therapy for rare eye diseases. I'll just be very quick in what we are doing at NN and what is the future, what will be the future in other diseases as well. So lysyl oxidase. Lysyl oxidase is something which is there in your cornea all the time in the stroma, and that is an enzyme, a gene which keeps your collagen bundles in place. And this is how it should be. But if the lysyl oxidase, the blue dots, what you're seeing is on the lesser side, your collagen bundles, they start slipping away. And that's when your corneal ectatic disorders start, which is known as keratoconus. And this is how it will be. So you need, so this is when the keratoconus happens, and if it's lesser, it keeps progressing. So you need optimal lysyl oxidase levels, which are these blue enzymes, and this is how it is represented in the cornea to have a good effect and to prevent the corneal ectatic disorders. Now, there are various publications which have happened where it suggests that the lysyl oxidase levels are lesser in the keratoconic eyes compared to that of controls. And with increasing grades of keratoconus, here you can see the lysyl oxidase levels are lower. So that means that lysyl oxidase is one of the culprits in your corneal ectatic disorders. And if the lysyl oxidase levels are on the lesser side, just to be a very quick brief, if it's on the lesser side, then even if you cross-link these patients, there are very high chances that these cross-linking patients are going to have a failure of cross-linking. So that is why lysyl oxidase is important. You might have very good collagen levels, but if the lysyl oxidase is on the lower side, then even if you do cross-linking, everybody will say that cross-linking is there for keratoconic patients. Why do I need a gene therapy? But if the lysyl oxidase level is lesser in your cornea, then even if you do this cross-linking, it's going to fail. That is why it is important. So the question here is that can we have a gene therapy in corneal ectatic disorders? I will not go into detail of what it is, but there is something like AAE vectors, which is nothing like a gene editing, where if there is a defective gene, when you inject these vectors, it goes to this defective area and it tries to edit that area and goes and sticks there. So that is what AAE vectors do, and that is what we have been working on. And as they just mentioned that how expensive the gene therapy can be, we have increasing disorders in gene therapy, and more people will need gene therapy with time. So what we are trying to do at Narayan Netralaya is we are trying to build our own clinical grade vector facility in India, where we can manufacture these vectors in India, and it will be a true made in India gene therapy for all the patients, and it will be as cost effective as possible because it's a true make in India product. So it's not easy to do a gene therapy. Like, it's not easy to build these gene therapy vectors because first of all you cannot have a lab and you can make these vectors. You need a class 100 room facility, a clean room facility where your normal person cannot go. You have to wear those space suits and go inside, and all the time you have to be in the space suits. You have to sterilize these rooms all the time, and then every product which you take inside also has to be clean, sterilized before you use it. So it's a lot of work which happens behind developing a gene therapy vector. And during any of this process, if the vector gets infected, your entire vector goes waste. You have to produce it again. So that is why this gene therapy is expensive, and it's not easily available, and it's not very successful. So what we are trying to do is we are trying to bring it in India and make it as cost effective as possible. Now, sorry. So now so the question comes here is, what route do we do? Like, because it's a corneal gene therapy, there will be retinal. So there will be various modes of administrations, like topical drops, intrastromal injections, intracameral injections, subconjunctival injections. So based on what level of the eye you want to treat, you can choose it. So we are trying to work on topical drops or intrastromal injections for corneal gene therapy, which will help us. So what we took two models to begin with. We took the mouse model where Dr. Tirumalesh helped me because it's very difficult to work in those small eyes. So he did intrastromal injections of lysyl oxidase vectors and the controls in those mice models. And then me and Dr. Rohit sir, when we were doing the smile surgeries, the lenticules which we remove, we did not discard them. We sent it to the lab, on which the same lenticule of both the patient, one eye got treated as with controls and the other eye got treated with the gene therapy vectors. We did it for 4 weeks. We treated them for 4 weeks, and after 4 weeks, we saw what the expression of this molecules was. So the first thing what we found was that if you can see these graphs, yes, it was working. These are all the contralateral eyes in the human donor lenticules. When you inject the lysyl oxidase vectors, the expression is increasing. The other thing what is increasing is when the gene lysyl oxidase vector increases, the collagen level increases, so that maintains the stability of your eye. But the other interesting part was, everybody talks about inflammation, keratoconus and inflammation. That whenever there is keratoconus, there is inflammation, and because of inflammation, the disease keeps progressing, and that's when your treatments fail. What we found interesting, the aim was never to treat inflammation. The aim was always to have lysyl oxidase, increase the lysyl oxidase vectors. When we treated this lenticules with lysyl oxidase vectors, the AEV vectors of lysyl oxidase, this is the control and this is the lysyl oxidase part, the inflammation actually came down. So
this is a very important thing which Ashish and Tirumlesh, Poonachand, all of you are, there are many retina surgeons here, is your driver of how a body reacts is determined by your genetic factors. Like you mentioned about TAS, we just spoke about TAS. Some people have a higher threshold of how they would respond to an inflammation, and it's driven by inflammatory genetics, inflammatory genes. And this particular slide was an eye opener, that you change the gene and your inflammation suddenly drops. And that's a classic example of how our body is controlled. And many times we blame a drug or a drop when there's an excessive reaction. It may be just that the drops may be behaving in excessive way because your body is genetically primed for behaving in excessive way. It's like emotions. I scream at her, I scream at him. The both of how they react would be different. That's the genetic. That's the molecules. That's why we call it as molecules of emotions.
So this is what we found, and that was a very positive point in our study, that just with lysyl oxidase therapy you can control inflammation. That will in turn help us in future as well. And the same findings we found on the mouse cornea model. So that was the same findings. But next what we wanted to do is we want to bring it to the patients. So when you're doing a phasic trial, before we inject this vectors into patient's eye, we had to see what will be the right route of this delivery, whether it will be drops, whether it will be intrastromal injections or what. So what we are doing currently is we have applied for a patent. I think today only they are going to apply for it. So what we did was we took cadaveric eyes, and we have we have tried different ways, but at this time we created a channel using the IFS.
IFS has a channel for used to have a channel for presbyopia implants. Nobody uses it here. I think Tejas used to use it once upon a time. So that's a good method to inject your vector, the virus inside.
And we injected him in the cadaveric eye, and we had to seal this wound because we didn't want the vectors to come out, because the squeezing of the tightness of the eye can squeeze it out. So we had to seal it with glue. And this is just initial data. Of course, these are healthy eyes, so we do not have lysyl oxidase for lower to begin with. But this is the control arm, and this is the lysyl oxidase arm. You can see how the collagen bundles, you can see the spacing between all of them. You can see some space here. And with the lysyl oxidase AE vectors injected, you can see the space of the collagen is getting closed. And here also you can see that how nicely the density of the ECM layer near the injection site is increased. And this is the second image. What you see is the denser the brown means more the lysyl oxidase activity, and here it's lesser. This is the control, and this is the vector. And so what we trying to say here is that it's working when we are trying to do a pocket, and it is increasing and helping in increasing the lysyl oxidase activity. And not just that, but this is an early work on the strength. So like you can do an
Working in the pocket area, or if it's working in general?
In general, because this was a histopathological
so this is the
thing.
entire cornea.
And what is important is, see, if you can see, there is no collagen at all. And suddenly with the gene, the collagen starts producing. And this is what you would see if tomorrow a healthy person's cornea is taken up.
So, but yeah, we need to still do more studies to see at how much effect it will stay and for how long. And this was done in goat's eye, where we had again injected these vectors the same way. And after 6 weeks, they had to be sacrificed. The goat's eye had to be excised, and we did nano indentation technology to see what if the strength, because of the injection of these vectors, whether the strength is actually increasing or not. And you can see the difference. These are the controls, and these are the LOX injected eyes. And you can see the increase in the elastic modulus of this corneas as well. So the LOX gene therapy can be a potential factor for keratoconic patients, and it also, in addition to it, also helps in reducing the inflammation.
We are just planning to hopefully bring it to clinical use this year once we get the regulatory affairs clear. Yes, Ashish? Sally, you can get ready. See, one thing which is, I understand where you're leading. For example, you're looking at retinoid pigmentosa, which is Pune is working on. You need a mapping because you have different genes which can be mutated. In lysyl oxidase, every keratoconic eyes, the lysyl oxidase is lost, irrespective of what gene is being mutated. So you don't need a candidate gene to be identified. For example, if he is planning for an injection of retina, you have to work on RP65 or in your Stargardt's ABC1. But here, the mechanism is that it's not there. It does not exist. So that is why it is much more easier on a cornea. In fact, we were looking at it whether we can use it on a drop format, but the drops does not go in. And interesting thing is, interest of time, we're not shown. You inject the gene. For Purna's also is the same child. How do you off the gene? It's like that ever-ready battery. The rabbit keeps running. So what we have to do is doxycycline is a regulator. So you have to use a doxycycline where you need, once you know it's getting stronger, you have to stop. In the first experiment, what they did with rabbits, you injected it, the rabbits died of heart attack because it made it whole body, the heart stopped pumping because the lysyl oxidase created non-functional heart. So experiments are really different. No, at this point of time, we have not really looked at what it could be. Drop, it could be injection. But when you inject it, that whole area becomes strong. That's what atomic force microscopy showed, that the strain suddenly becomes very strong. But the challenge is about stopping it because we don't want it to keep doing it all the time. We have 2 more talks and then we can discuss. I made her to talk first because Tirumale's talk is more barbaric on animals, and Saili will start crying because she's a big animal lover. So we decided that she has to speak, and she doesn't eat anything which is anything to do with animals. Tries also to wear and doesn't touch anything where they use animals for anything. So it's important, and a lot of experiments we did now. We are moving, our lab is more moving away from animal, and I would say around 80 to 90% of work we have been bypassing the animals into except for what Tirumalesh is trying to do, because still we are not able to find a source there. So she'll be very quick, and we will end in next 5 to 10 minutes.
Good evening, everyone. So I'm going to be talking about one of our prized inventions, the polarization sensitive OCT, which has helped us image the collagen. Why is this important? So with the evolution of screening indices in refractive surgery, we have a lot of tools at our disposal. We have the tomography, the biomechanics, the anterior segment OCT. And while these certainly have made our lives easier, we still have dilemmas where we end up with cases such as ectasia. Now, there are patients with absolutely normal topography and biomechanics that end up in ectasia, and similar kind of topography may not. What are the current screening indices missing in these cases? Another thing that we face is when the topography and the biomechanics don't end up matching, and we wonder which one to go ahead with. And also the post-operative outcomes that we see in a lot of our cross-linking patients tend to be variable, so we don't know what exactly is happening here. Where are we going wrong? Now, while the present-day indices which we're using, such as the tomography, biomechanics, all of these assess the corneal surface and the corneal structural integrity, they do not provide much information on the corneal microstructure. We all know that the disease, any ectatic disease, starts in the stroma. It starts with the collagen. So while we are assessing the surface, we should be assessing the stroma. We already have some modalities for these, such as scanning electron microscopy, in vivo confocal microscopy, and lysyl oxidase, and these tend to be either cumbersome or invasive and are not always feasible. So that is where we introduced the polarization sensitive OCT. We built it with collaboration with the Medical University of Vienna. And basically the principle is that it measures the manner in which the light incident on the cornea is altered. So it measures the alteration in the polarization status of the light. And this is the information that it gives us: the epithelium thickness, Bowman's stromal thickness, the collagen orientation, and the OCT image. And it is the first ever tool to quantify the Bowman's layer thickness, which is in clinical use. And this is how we interpret the map. So basically, the normal arrangement of collagen fibrils in the human cornea is a checkered arrangement. So you have least phase retardation at the apex, and it continues increasing towards the periphery, where the arrangement of collagen fibers is denser. This is how, these are the results that we noticed, where in normal corneas, the arrangement of collagen was what we previously saw. With FFKCs and suspicious corneas, there was partial loss of orientation and arrangement of collagen. And you can see what happened in keratoconus eyes, where there was complete loss of orientation and collagen arrangement. So how is this useful to us in the clinics? It can help us guide when there are dilemmas with respect to topography and biomechanics. We can always resort to this, where patients with normal PR and thick Bowmans, you have your own preference. In patients where there is a mismatch, you would rely on the refractive error to decide which surgery to go with. And in cases where both are abnormal, it would be safer for the patient to undergo a phakic IOL. We also assessed the post-operative change in PSOCT, and we found out what we already know, that PRK causes minimal change in the collagen orientation, and there is moderate change with SMILE, and the most significant alterations are seen with LASIK. So we already knew that histopathological changes in the collagen tend to precede clinical changes in ectatic disease, and there is a paucity of technology in investigating these. We could use Bowman's thickness and the structural integrity of collagen as a potential biomarker for assessing a progression of ectatic disease and also for screening. Ongoing building of these indices will help us strengthen our protocol. This is our ongoing work where we are also assessing the fibril orientation of collagen, and that has helped us assess the results of cross-linking, where the disrupted orientation tends to improve after cross-linking, as you can see in this patient.
Thank you.
Yeah.
Thank you, Sally. Any questions for her? And the first question is, when is it going to come? Oculus is one company which has been very keen on this. At least there are 2 or 3 other companies where they want to incorporate in the next generation OCT, because the most beautiful power is to look at collagen itself. And this is not just in cornea. I think a lot of, I think from a retina, Puna, would you want to say anything when they're connecting? How does this, with the resolution of 1 micron, have an impact in compared to your 6 to 6.5, 4.5 to 6 microns of, say, Heidelberg or one of the OCT? You've done work on PSOCT in retina. I mean,
no, the fact that it considers the polarized status of the reflected image, it will also kind of giving, in addition to the resolution, the functional status. For example, if I take an example, RP, which is very much degenerated, if there are some functional photoreceptor which are left, that the polarization part will be a different compared to a degenerated part. That's where it becomes very sensitive. Even if it's you have an half micron resolution, it cannot match this.
But simple question is, for example, clinically you define wet ARMD, dry ARMD, and all these changes. So do you think that will this, I mean, this is defined based on your FFA or OCT. Do you think that when you do work on it, the cellular, if you're able to identify cells, do you think that your decision would be different?
Obviously it will be different. Obviously it will be. In fact, for dry ARMD, so far we are injecting VEGF left and right. Now people are coming up with an like inflammatory pathway for even the dry ARMD. So far we are looking at only vascular VEGF, and people have started. Okay. Yeah. Mm-hmm.
So probably in a vertical, we do not, it goes to the choroid. So what he's asking probably is horizontal resolution, whether what cell would you be able to...
Yeah, to answer this question, we are looking at, with the present thing, there will be a limitation still, I think.
Yeah.
But we are building a different optics of adaptive optics on it. If you build an adaptive optics, your resolution becomes less than 1 micron. And minute you see that, you will start seeing rods and cones.
Yes. And also the major limitation, these are central disorder. The focus is very important to capture these images. That is one thing. Once we have the adaptive, that might answer the question, and also it will make life easier for us.
Thank you. This is a very important talk, and it's important that all of us should know how many of these drugs are tested, because many times it's like we should know how somebody is putting an effort to cook. If you don't look into their kitchen, then you assume that everything comes by magic. So drugs are always developed like this, whether you want to use a blinder on it, or you want to put an effort to understand this. And Tirumlesh is important because he's one of the first few who actually wanted to work on an animal model himself, hands-on work. Many clinicians would not want to do that, and he became so good at that that he's better than a lot of our lab scientists who actually work on the animals all the time. Interesting, Dr. Mohita. Small trivia. I mean, a lot of us here are dog lovers. Arka used to tell me when he worked on the gene therapy work with what Pooja said, initial work, he has a patent for the AAV vector on Stargardts. You actually have to work on dogs because that's the end. Imagine you take a 2 3 big labradors, they grow with you, they're in your lab for 4 5 years, right? And you create a model for them to go blind, means it's not blind, and then you inject it and you have to euthanize the dog. You have to kill the dog yourself, and until unless you're able to do it, the lab will not take you. You can't say that I'm not going to do this on my lab. And those dogs you're grown with, they're not something you got from your pet shop. So it is science, or advancement of science is not as simple as we have understood it to be. Quickly, just go to quickly few slides. I know you have a long list of it, but
Actually, thank you, sir. Why we require animal model is because the same kind of disease, you can see here that the amount of hypoxia and the amount of neovascularization does not match. In this slide, you can see although there are peripheral dropouts, you can see the neovascularization is more central. In this particular slide, you can see the capillary dropout is not too much, but still you see neovascularization. So there is no standardization when it comes to how patient present to us and what is the level of the disease. So before going into how we develop the model, we usually collect data. So before I joined NN, already NN was in this process where we had collected the aqueous and we analyzed many factors based on the cytometric bead array of the aqueous. Based on that, we narrowed down to few targets. So we already know that VEGF-A is already predominantly targeted and steroid kind of carpet bombs everything. But we hit on a soluble ICAM molecule because this was something which was present both in treatment naive patients, but it kept on increasing. And the good thing about ICAM is that ICAM is present right from the beginning. So these are the two guardians of retina, the endothelial tight junctions and the RPE tight junction. So whenever you stress these two cells, the first molecule that responds is ICAM, which means that this is the initiator, this is the one which is present during the disease process, and this probably is also present in the proliferative disease phase as well. So that is why we chose this particular molecule. And this is how we stressed the RPE. We took a cell culture line and we produced different kind of stresses and we examined the expression. So whenever we put them under stress, both hyperglycemic or hypoxic, they produced ICAM. So based on this, if you remember diabetic retinopathy, we said that whenever there is hyperglycemia, there is going to be leukostasis. That is one of the first thing to happen. Now, what produced that leukostasis within the intraluminal side is the expression of this ICAM. So that was the reason why we started modeling this, and we checked it before we went up. And many might ask a question that, oh, you were looking at aqueous. So this is a soluble protein that you're looking at. Does the RPE and the human choroid, does it have these ICAM? So you can see that in the donor eyes, we were able to, in diabetic eyes, when we examined, the ICAM was active in all of them with the fluorescent antibody. So going to the animal model, so we know that SD rats is the standardized diabetic rat model. So we took the SD rats and we gave an intraperitoneal injection of STZ, which produced diabetes in a period of 12 weeks. So after 12 weeks, what we did was we gave anti-VEGF, which was ranibizumab, because that is the standard of care molecule. And we used our LFA1 antagonist, which tends to block the ICAM level. And what we did was, before we sacrificed the mice after 2 weeks, we put a FITC-Rexten in its tailwind. FITC-Rexten is like fluorescein that we give for patients, but in rats we use FITC. So this is what we saw. In the rats which were sacrificed without any diabetes, you can see that the vascular integrity is well maintained. Rats do not have macula, so any part of the quadrant would look very similar. So you can see that there is absolutely no leakage. But the moment we examined the STZ rats, which were the diabetic rat model, you can see that there is extensive leakage, presence of microorganisms and all that. So if we add the ICAM to this, the leakage became more pronounced. You can see between that slide and that slide, that is more brighter because it's leaking from everywhere. So along with VEGF, ICAM definitely has a role which shows that it not only produces the disease, it also increases the severity of the disease. So our hypothesis kind of became more and more stronger. Now, when we add the antagonist, you can see the beauty of it that from there, it came there. and it was as good as the anti-VEGF. In fact, if you look between the anti-VEGF and the STZ, I mean, and the LFA1 antagonist, which I put side by side, this can even produce stability of the endothelial tight junctions as well. So we were thinking that this is one molecule which probably would influence the treatment as it goes further. Now, to make the hypothesis a little more stronger, what we did was we took the wild type rats, which were not transgenic mice. We did not give them diabetes this time. What we did was we used a vector and we overexpressed the IK molecule. And we did not feed it anything differently, but you can see between the control molecule and the ICAM expression, overexpression molecule, you can see there is definitive presence of microorganisms which is already there in that part. If I can show there, right? So this makes more and more sense that ICAM definitely has a role, and this particular molecule can play a role in future. So the second part of it is AMD. India is a very young country. That's why we became so popular with the US, that they were outsourcing our people to there. Very soon we are also going to end up in an AMD epidemic. So that is one of my very interested topic which I'm working on. And Dr. Sina is our collaborator at Pittsburgh University. Because India does not allow studies on monkeys and chimps, so the NHP studies are done in Seri by Dr. Bharti. So you know that AMD has about 200 different genes. But the beauty of it is, if you knock off any of those 200 genes, you will never be able to produce a AMD in animals, which means that every single gene that has been reported till date is an associative gene at best. It's not a causative gene, right? But Dr. Sinha's lab stumbled on this particular gene, which I'm not supposed to reveal, so I have not revealed it. But when they produce a knockout of that gene, the beauty is that they produce the first model which actually can show drusense in mice. I mean, drusense in mice is something which is absolutely unheard of. And when we were working on it, we found a transgenic sequence. So NN is providing the transgene, which is being produced in India at our lab. And we are also producing the vector here. So they are providing the expertise of the gene sequence, which is supposed to be altered. So that's how we are working. And we are already finished the rodent trial, and we are in the non-human primate model. So this is one drug which will very soon come, and this is something where you can actually start giving in patients at some point of time, probably a span of 2 to 3 years. And current existing molecules talk about gene therapy where you have to do a vitrectomy, induce a retinal detachment, and give a subretinal injection. So if a AMD patient comes, you're going to tell them that I'm going to detach your retina and give. That patient probably might not really agree. So the challenge that the university gave us was, can you give us a slightly better option? So at NN, we have developed a patented needle, which can allow the molecule to be delivered into the suprachoroidal space without any retinal detachment. So ideally speaking, just like how we give an intravitreal injection, this particular drug can be delivered at office. And we use the same needle. I'm not showing it because of patent issues again. So we delivered the drug, and you can see in baseline first and second injection, whatever we have seen, it has not produced any toxic effects.
And now I think, if I'm right, you are moving this from
Primates to
small
humans.
primates to chimpanzees.
This is in chimps already, sir.
Chimps. So chimps, we don't have an animal model of chimps in.
So we are
India.
aging them, and then we are.
So they go, yeah. So we'll have to work with Singapore Eye Institute for work on a bigger primate, because that's the only one which is closest to.
The first thing they wanted to know is it toxic? So we followed them up. We did an OCT. We did in the post-injection fluorescein, and there was no toxicity at all.
I think
And
that should be
this is the last one that I would want to show. That is it effective? You can definitely see that the gene that we gave was able to produce presence of the RP, which was almost dying. It did tend to revive it in all of the
the green one.
The green one, the hyperfluorescent one, is proof that this gene gets integrated and actually alters.
And this is on what animal?
This is the chimp only.
Okay. Any questions by anybody? This is the last one. So basically, I think, like the sir mentioned, there is a lot of work we can work together with collaboration. Dr. Mohita has shown this, and companies like Cipla have to look beyond just organizing meetings. You'll have to look beyond, like you have done work with Sharon. I think ultimately it's going to help you. We have Dr. Suzuka Ko from visiting from Japan. You want to add anything? She is a cornea surgeon in Kyoto University and does a lot of work on biomechanics. Has been her area of work. So you have an animal house lab in University of Kyoto. Kyoto is known for more of optics. Osaka, yes. Anybody has anything? If nobody has any questions, thank you all. I thank Cipla for this wonderful event. And Nitesh, you want to say anything? Absolutely. Dr.
Continuing with this kind of good work, whether it is
So-
form of rare disease or it is in a form of a disease which is very well known to us. And the way, yeah, the way the sir was talking about, I think Cipla was the first organization which developed depriprone for thalassemia patients. And this is an iron chelator, which is thoroughly, it's a service product for the pediatric population of the patients. And there are a good number of drugs which we have introduced only for this kind of population where nobody else is there. And we'll talk about pandemic, we're talking about COVID. COVID was, I think, such pandemic where Cipla has come out full-fledgedly with all kind of drugs, whether you talk about remdesivir, whether you talk about Actimera, whether you talk about collaboration with everybody. So we are always there to help, and for us, we also say that the patient comes first, and with you, we try to reach to the patient. That's our objective. Thank you everyone.
It's just a suggestion. So now you can do large animal studies in India, and it will take only 1 month to get it clearer. Okay? Not me, to the large animal committee, not me. I am not responsible, but this is the latest.